I'm George Dangas, and very much pleased to be part of the faculty in this great congress of the Internal Heart Center, a very famous center here in New York because Dr. Sharma and many of his fellows and many of his associates are working with and making a distinguished center in northern India and in all of India year by year, even more so. I've always been impressed by what I hear the accomplishment of it has been in intervention, in TAVR, even in transplant and heart surgery. Congratulations for this Congress. And I would like to now share my screen and start the presentation on renal denervation status 2020, a very interesting subject. And here we are. In this subject, I have been the principal investigator of the renal denervation program at Mount Sinai for a few years, and that's why I declare this as one of my important disclosures on this slide. First of all, why is hypertension very important? It's very important because it impacts mortality on a population basis. Even with a very small reductions in blood pressure, they reflect a significant reduction in overall mortality and morbidity. You can see that even a 2 millimeter of mercury decrease in mean blood pressure of a population, something that all of us might consider minuscule or even unimportant, even that is translating to a 10% reduction in risk of stroke-related mortality and a 7% reduction in ischemic heart disease-related mortality, which both of those, none of us would consider trivial. Quite the opposite. We consider them very important. The renal nerves and the sympathetic nervous system has a very intriguing and a very important relationship with the brain in a way that we don't fully understand, but we do know that the brain and the sympathetic nervous system affect a lot the tone of the renal arteries and essentially affect the thermostat of the blood pressure of the body, which is located in the kidneys. Along these lines, renal denervation attempts to potentially destroy both the efferent and the efferent nerve fibers, thereby disrupting this feedback mechanism that leads to a very high blood pressure in certain individuals. And before any other slide, let me just share this anatomy slide so that everybody can understand that the renal sympathetic nervous system is a part of the abdominal sympathetic nervous system that is derived from the stellar ganglion, which actually located up in the chest, and from it, all the fibers distribute to the various organs on top of each organ's vasculature. So on top of each organ's artery, on top of its adventitia are the various sympathetic nerves. So thereby, if we have a catheter with an electrode that emits energy in the lumen, as you see in the magnified picture at the right, we're on the vessel lumen at the top of that picture, then we have to essentially find a way that our energy is confluent on different areas and hits our target, which is going to be about a 3 millimeter depth, because this is approximately how thick the renal arteries are, and find, hit, and destroy the renal nerves. Now, because the renal nerves are circumferentially around the artery, we have to hit the artery in all 4 quadrants in order to disrupt all the nerves all around the artery, not just in one area. This field has been, one may say, overcrowded since the proof of principle, the very beginning, the simplistic hypertension 1 trial, is the first interventional trial in the area. And one can go even 30 years back and find surgical studies employing cut of the fibers at the stellate ganglion, a surgical procedure, and that had favorable case reports, but for obvious reasons, it was deemed not a very beneficial risk-wise, because after all, it's a chest surgery. So anyhow, you can see that since we started these attempts to denervate the renal arteries via catheter on different companies, different trials, different catheters, single goal, and still, nearly 10 years later, we are in the search for the good, clear clinical trial results. And not only many, I would say, companies and catheters, but also many targets. You can see on the top left, we have denervation aspects, neuromodulation directly at the heart level to something like a pacemaker, essentially, an implanted generator, or at the carotid bulb level that we have the top right, or we can have the more classic radio frequency or even ultrasound, and even lately some alcohol-mediated renal denervation. I'm not going to cover the latter because I think it's just too much for this short talk. In general, the aerial view is the two ways one can measure and assess hypertension. The very common office systolic blood pressure and the more accurate 24-hour ambulatory systolic blood pressure assessment that also includes assessment during the night and includes the certain people, very high-risk people, quite frankly, that have nocturnal hypertension, which is kind of counterintuitive because in most people, in the majority of people, the blood pressure goes down during the sleep. But in some people, it may paradoxically go up. And these people may be at particularly high risk for adverse outcomes later in the future. One can see that out of several trials, 45 published trials analyzed here, we have a, I would say, very consistent, favorable effect in both office and ambulatory. Maybe the numbers are a little milder in the ambulatory. They're at the minus 10% range. In the office, blood pressure are in the minus 20 range. Again, there may be a little bit more nervousness in patients visiting the office, but in general, there is a benefit seen by either one of both. Then, needless to say that any study that employs an ambulatory blood pressure monitoring is a very difficult one to rather enroll as well as complete because of the more painstaking aspects of this type of investigation and patient compliance or non-adherence, one could say. Let's look at the spiral hypertension program, which is a new catheter that you can obviously see it's spiral. A picture of it at the top right, and you can actually assess the two pictures, the angiographic pictures in the renal artery. This catheter is delivered via a guiding catheter from the femoral artery over a wire. The wire can be advanced in the branch renal arteries, and you can see how the electrodes are seen at the bottom picture, and they are longitudinal. Interestingly, the catheter hugs the wall of the artery in a way that you can see at the top picture that actually the electrodes, although they seem longitudinal at the bottom, they're far from being on a straight line. They are actually occupying all four quadrants of the artery, and therefore we have a capacity to actually, with a single zap, we can select from one to all four electrodes to zap at the same time. We can actually complete the 60-second simultaneous ablation all around this artery with one at one time frame. And then the artery is pulled back and does more denervations at the renal artery, main renal artery, and at the proximal part, and then it is then completed in this area and then moves on to another area or to another renal artery or to an accessory renal until all is denervated. Very simple one, must say. 6 French system. A very important trial. Actually, the first trials was to try to denervate patients who are resistant to many drugs. And this is what we call now hypertension on-med clinical trials. In this type of trials, the patients have to have a systolic hypertension of a certain range, 150 to 180, because we don't want to investigate patients who are at risk of a hemorrhagic episode with blood pressure near to 200, and also we don't want to investigate people with only mild high blood pressure. Anyhow, the most important aspect of this trial is that once you decide what's a medical therapy you like or the maximum tolerated, you cannot further change it. And if you change it, the patient is kicked out. Also, if during the various screening visits, the patient is thrown off this desired range, then the patient is again thrown out. And then at another level, the patient is completing a 24-hour blood pressure monitoring. If they cannot complete it for any reason, or if it's low quality, then again the patient is thrown out. Then you go ultimately to randomization on the table. And again, you have all sorts of exclusions regarding to the takeoff, maybe some lesions in the renal arteries, even around 50% is an exclusion. A lot of complications in how to actually get a patient in. No wonder why 1 in 10 or 1 in 15 patients only makes it into the trial. We may have many, many people who screen out for many reasons. No wonder this trial is actually a smaller a small-sized trial, and we only have a proof of principle initial cohort published, and the results are the ones that you see here. A systolic blood pressure decrease of a mean of 9, and again, this is an ambulatory blood pressure monitoring. In the office could be even double that perhaps, and a decrease in the diastolic blood pressure by around 2 or maybe 3. Then we go to another population, which is patients who cannot have or will not have or have side effects with medication. Essentially, we're off meds. And again, as a previous study, every study that I present today pretty much is a sham control, because we know that if there's no sham, there is a lot of bias in these trials. And again, on the left side, you see the very complicated and complex screening with multiple visits and necessity for a range on 50 to 180 of the systolic blood pressure, the ambulatory blood pressure monitoring requirement, etc. And ultimately, the patient is entering the study, following up initially for a few weeks, and then completing for a 3 month, and then have a drug titration. I don't want to burden you with the delays. I just want to give you the idea that any new antihypertensive drug that wants to go into the market by the FDA has pretty much a very similar trial to go through. So that's why this catheter goes through to this, one must say, a little strange study design for interventional cardiology. This is because it mirrors the hypertension drug approval process, or pre-approval process to be more accurate, because none of these catheters is approved for use in the United States yet. It's approved in Europe. In off-meds trial, again, we had a significant reduction, again in the range between 5 and 10 on average, and a diastolic reduction, again, in the range of maybe 1 to 3 millimeters, both significant, and one must say, both modest. Nonetheless, on the right direction. And again, remember, this may be in some ways maybe a minority, one may say, but clearly patients who cannot or will not or do not want or cannot tolerate medical therapy. Very important to know. Another type of catheter is in the Radiance hypertension catheter. Again, is a sham controlled and with a renal denervation trial. And again, you can see this is based mostly on office blood pressure monitoring. And one can say that the no antihypertension medication changes unless the escape blood pressure criteria is exceeded. And again, this is an important part to know that once you enter these trials, you cannot allow the doctors to just going up and down on the blood pressure medicines, no matter what that value is. And during the study period, they have to all agree to freeze the medical therapy, because otherwise the study gets muddied. And at the same time, I must tell you, a lot of doctors find that very hard to actually do. And they want to just react by shuffling the medications one way or another if they feel it goes up or it goes down. There's a lot of nervousness while doing these trials. It's not easy to ask the doctors to just freeze their medical assessment for several months. Anyhow, this trial empowers the ultrasonic heating, and it's a balloon essentially that that allows an endovascular ultrasound ablation catheter. This is a Paradise catheter by Record, and they had again the similar flavor of reduction, mostly in systolic blood pressure in the area of like 9 millimeters of mercury, and diastolic blood pressure in the area of or a smaller area. Compared to sham had about a 2 millimeter of mercury decrease. And the interesting part is that, as I said, some of these catheters are approved in Europe and other countries, in other parts in the world, and including India. And you can see that in this, from these areas, they have registries going on. And during these registries, obviously, a much more liberal population is included, essentially checking of resistant hypertension, of difficult to control hypertension by clinical criteria. Again, on multiple medical regimen, of course, before. Again, the flavor similar with the perhaps a little bit accentuated. Again, there's no sham control here, but the main message of these registries, in my mind, has been that you don't see any erosion of the result between 1 and 3 years. So, although we may say that in reality, maybe with the sham control, maybe the difference is not going to be that big. As we said in the sham control before, there was like maybe a -9 or 10, and the control groups we saw, there were maybe a -1 or 3. And over here, we see maybe a 20 millimeter of mercury decrease. I would not stay on the 20, but I would definitely stay on the fact there was not a lot of difference between 6 months and 3 years. So I keep the durability as the main outcome and the main finding of these clinical registries. So as a conclusion, I'd like to say that we're in a very interesting turn. We know that this possibility is a durable, for us, a durable result. The result is not as big as we thought. That is a minus, one can say, but also a plus, because it hasn't been associated with any adverse events as far as too much orthostatic hypotension or syncopes. We hadn't really had any renal artery complications to speak about. A lot of us were concerned regarding maybe restenosis, thrombosis, aneurysms, a lot of things. None of those really panned out. Renal failure never became an issue, and only a few patients here and there had some kind of a femoral artery access complication that we can all understand, because this, after all, is a femoral arterial access required of 6 French for this procedure. And in a hypertensive population, clearly there may be some growing complications. Aside from that, a procedure at the kidney level have been really minimal. In this background, we can say that the second generation sham-controlled trials of renal denervation have provided a good proof of principle of the blood pressure lowering efficacy with radiofrequency-based ablation, as well as with the ultrasound-based renal denervation in patients both with as well as without concomitant pharmacotherapy in this kind of pairs, if you want, or twin type of trial designs. When we consider device-based renal hypertension, the underlying pathophysiology had also been taken under consideration, and the procedural risks, primarily, as I said, the growing complications against a cardiovascular risk attributable to elevated blood pressure for each patient. So that's what I say. I think ultimately what the registry see is maybe a very different population, because for the trial, there's so many exclusions at so many levels. You're just not going to have the same people that are out in the community with multiple comorbidities, and to a certain degree with very variable blood pressures and very difficult backgrounds, possibly impossible to freeze antihypertensive therapy for so many months out in the community. Finally, in my mind, we're going to now gravitate our future look into clinical trials focusing to on-meds population, multiple meds, still I cannot achieve good control of hypertension. That's one population. And then the other population would be no medication or almost no medication, because the patients are intolerable or they have some side effects which they cannot cope with. And this type of things, there'll be 2 different patient populations. Both of them are very important candidates for this type of therapies. And I think we're gonna stay tuned for more advances in this aspect in the near future, with completion of more trials and larger trials, and perhaps they may lead to an FDA approval in the United States and may change everything. In the meantime, I would totally recommend a wider participation in the clinical registries everywhere in the world that these types of therapies are already approved. Thank you for your attention. And again, best greetings from New York.